Okay, perfect. Yes, ma'am. She's like, get it yourself, girl. Get it yourself, girl. What would you like? Fruit and wraps.
second meal up.
Heck yeah.
Sorry about that. Am I going to run again? Oh, that's right. I'll drop that off for you. You guys are still there when I get out of here. I'll drop it off. Thanks for the sympathy. Yeah, thanks for calling. I appreciate it. I was looking for it. All right.
Yeah, you know, I believe there. I'm probably just not looking in the right place.
No, that's okay.
Bill, where was that?
We usually have some. Let me grab you some.
Thank you.
I'm not ready to get there. So I'll drop off. Definitely off.
everybody. Someone introduce him? No? Sure. All right, I wait later. What? No, why? Hey. Can sit there. Oh, starting? Yeah.
Thank you all for coming. I see a lot of familiar faces that are patients of Dr. Patel. So those of you who don't know him, he has four certifications. He's a regenerative medicine specialist. And tonight he's going to be talking about regenerative medicine, specifically stem cell therapies. So he'll talk about 30 or 40 minutes, and at the end there will be a Q&A session where you can get all your answers or questions answered. Okay.
Welcome. So today I'm just gonna have a brief talk about something we call regenerative medicine. It's a brand new medical field emerging, and the goal for these treatments are to reverse the changes or the damages happen to the body over the years, and that's happening. So what is regenerative medicine? It's broadly deals with using biological materials.
We can't hear.
You cannot hear?
No, there's too much background noise. Turn the sound down.
I'm not IT, so bear with me.
Thank you.
He's out there. Oh.
Sorry about that. I was trying to get the music off. Told you I wasn't IT.
Yeah, that is definitely music.
I got it off though, right?
So basically we're talking about the regenerative medicine. It's a brand new field emerging. People has been using platelet-rich plasma and stem cells for a while now, but it's getting more popular because there are more and more studies coming out that it's really working for the different diseases. We deal here with the spine conditions as well as the non-spinal condition. We call as a musculoskeletal medicine, but stem cells has been in use now to treat many systemic disease. People are using, or the doctors using for to cure the heart disease, cure the lung disease, liver disease. They are working diligently to get treatments for the cancer pain. So it's a wide variety of use. The military is starting to experiment, and they're actually rebuilding the ears and nose through these stem cells. Are they applicable to the public yet? We don't know. But in the musculoskeletal medicine, there is a significant increase in use of platelet-rich plasma and the stem cells. And as the slide comes up, medicine we call use of biologics. Biologics means it's just biological material, and it's mainly we use called autologous, means your own. So we use our own blood, we use our own bone marrow, we use your own fat to get the something we call platelet-rich plasma as well as the stem cells. And I'll show you a little bit more detail about those things as I go through the slides. As I say, musculoskeletal conditions, people are using for disc disease. They are using for the joint injections, mainly the knee joints, hip joints, shoulder joints. We also using for chronic inflammatory changes in the tendons everywhere in the body, like common is rotator cuff tendon tear. I don't know if you guys heard about the tennis elbow, where the pain with the elbow, plantar fascia, Achilles tendon. There's a wide use in athletics too, for the acute injuries, and I will show you some of the athletics that they went through this therapy, and there's just a short list. Okay. So again, this is just developing field, so lots of research coming out, but lots of musculoskeletal physician has been in use, and we have started use of the Duke spine for about a year or so. And then here we got IT.
So has it been successful with osteoarthritis and joints?
Yes.
Yes. Good. Do insurance companies recognize it?
Nope. Not yet. But the problem with the treatments we have, existing treatments we do right now, I don't know, it's in a use sometimes 50, 60 years old, and they are coming out now and saying that, oh, that's experimental, we're not covering. So I'm not sure. But eventually, if they see how much money they can save by paying for this over the time, they may start covering. But at this point, there are no indications. At least I say platelet-rich plasma, when we do in Medicare populations, we have been recommended or asked to at least bill it. They don't pay for it, so they can track it, how many physicians are using, for what conditions they're using, and obviously they look for the success rate. So that's another way they can probably see that it's really successful and it's worth to pay for it, to save the money in the long run. So regenerative medicine consists of something called platelet-rich plasma injection as well as stem cells based therapy. And the combination is also known as something called biologics. So that means it's a biological material. These studies and this foundation say that stem cell hold the promise of treatment and cures for more than 70 major diseases that affect millions of people. And this is not even, we're talking about musculoskeletal, we're talking about all other systemic disease like heart problem, emphysema, asthma, COPD, blood cancer, and all those things. So first we're going to talk about some platelet-rich plasma. So what is platelet-rich plasma? So platelet-rich plasma is a supraphysiological concentration of platelets in a small volume of plasma. In your own blood, the platelet numbers varies about 150 to 400,000 per liter. When we do the PRP or platelet-rich plasma, that concentration is 4 to 8 times the normal concentration. So you have almost $1 million to $2 million platelets in the same volume or the same milliliter to the liter in your blood. So what are the platelets? Platelets are very small disc-shaped components of blood cells, same like white blood cells, red blood cells, and platelets. They are 3 major blood cells. They derive from the bone marrows, as all other blood cells comes from it. Generation. Their average lifespan is about 5 to 9 days. So once they come out of the bone marrow as a adult platelet, they usually gets destroyed within 5 to 9 days by the spleen. What they do, they have lots of growth factors. So when they lysis in the tissues, in the blood, they release lots of growth factors. They contain 3 types of granules. This is a little bit of physiology. And so far, scientists has found they have almost 1,100 types of proteins. And this was, I looked probably a few months ago, so I don't know, maybe it's 2,200 now as the research keep going. So power of platelets, this is the busy slides, but this shows There's tons of growth factors the platelets can secrete, and those all are involved in a tissue regeneration. So platelet-rich plasma has a very high concentration of growth factors that derive from the platelets. What they do, they stimulate the cell replications when they make the cell to regenerate, to replicate themselves. They promote the angiogenesis, means they lead to new blood vessel formation. Blood vessel formation and bringing the blood to the damaged tissue is the #1 priority to healing. That's how you get all these nutrients to heal the tissue. If your tissue doesn't have blood supply, that tissue is never going to regenerate. You cannot regenerate the tissue without blood supply. So the platelet-rich plasma and platelets helps to regenerate new blood vessels growing to the new tissues. It leads to the new tissue formation, extracellular matrix formation. All those includes basically to regrow the damaged tissue. And if you apply the local application, or you apply the high concentration of growth factors at the one time there, obviously it works very well. It also has antibacterial effects and a microbial killing activity. These platelets can lysis and releases some enzymes and actually kill the bacteria. So when we do the injection, when we say, hey, we're going to do the steroid injection, there is a risk of increase in fraction. Well, when I do the PRP injection, there is some risk of increase in fraction, but at the same time, platelets can kill the bacteria. So compared to the steroid injection, PRP injection has less risk of infection because you already put something there that's already killing the bacteria. This is just biochemistry showing that platelets releases these growth factors and called cytokines. Growth factors signal the cell division for the tissue growth. The cytokines signal other important cellular functions to regenerate the tissue. So when the healing process happens, you injure the tissue or you injure somewhere in your body part, it takes 3 turns or 3 ways tissue can heal. One is it just heals by forming the scar. The scar is a non-functional tissue. Scarring cannot do anything. There is no function. It's just a scar, dead skin, dead tissue. It can lead to partially function tissue, means if functioning partially, less scarring, small scarring, the tissue is not working. And then normal tissue formation, where is a fully functional tissue, the same tissue as before the injury. So that's how the healing process goes. Once you injure something, it can be one of the 3 ways it heals. So when you inject the platelet-rich plasma in the injured tissue, what happens? The platelets are involved in the tissue healing, and it speeds up the process of repair and regeneration. So you add supranatural levels of platelets, it can lead to faster regeneration and a smoother regeneration, leading to the formation of the normal tissue formation instead of the scar formation or the partially functioning tissue, as we talked before. So how we get this platelet-rich plasma? First, we draw your own blood. So we draw about 60 cc of blood if you want to get the 6 cc of the fluid. The amount of the fluid you inject in the tissues depends where you're injecting. So if you're injecting the joints, the big joints like knees and hips, you have to inject about 6 cc of platelet-rich plasma in each joint. So if you're coming for both sides, I have to get a 12 cc of platelet-rich plasma. So I might have to draw more than 60 cc. You might have to draw 120 cc fluid. After that, we usually put the tubes in the centrifuge. I don't know if you guys know the centrifuge basically spins the blood. And when you spin the blood at a certain speed and gravity force, you have the first spin will divide the blood in 3 layers. The lowest layer is all our red blood cells. The top layer is called plasma, and the plasma is just a serum. It has very small amount of platelets there and some white blood cells. This middle layer called buffy coat, he has a concentrated platelets there and some white blood cells. Then what we do is we basically take these out, discard the red blood cells because we don't want red blood cells. We want these, and we transfer that in the different tubes, and then we respin again. When the respin happens, you can see this is the first spin. So you can see the plasma, buffy coat, that's platelets and some white blood cells, red blood cells. We took these out. We did the respin. When you respin it, now we have this plasma here. That's we call platelet poor plasma. Means it has very minimal amount of platelets, more white blood cells. But on the bottom here, you have concentrated platelets there. All the platelets are stuck there on that glass tube and in the fluid. So what we do is we take this excess thing out, leave about 1 to 2 cc of fluid in each tube that has lots of platelets, and then we basically shake it to reconstitute, and we basically aspirate that in the tubes, and that's what you get, the platelet-rich plasma. So this is the one we want to inject that has lots of platelets in your plasma or serum, some little bit white blood cells, little bit red blood cells, not too much. So when we aspirate, we try our best not to get too many red blood cells in this fluid. And then after we get the platelet-rich plasma, we do the injection where it's needed. Very important to do the injections under the guidance. Guidance means we use either ultrasound guidance or the fluoroscopic guidance to make sure we inject where it's needed. If you want to inject in the elbow joint, injecting right outside the elbow joint doesn't work. If you want to inject the lumbar disc or lumbar facet joints and you just inject in the lumbar paraspinal muscles, it doesn't work. It does not migrate. You have to put inside there. But that tissue already damaged. As I say, there is no blood supply going there. Then injecting outside, not going to carry that into that tissue. So it's not going to work. And you're not going to be 100% sure unless you use the guidance. So if you do the blind knee injection, it can work. But there are the case reports or the study shows that when blind injection done for the knees, 30% of time you're not in the knee joint. So then it's not going to work. So it's very important. You have to make sure it's in the tissue you want to inject or in the joint, not outside. So we'll talk about stem cells now. The stem cells is like a Lamborghini compared with the white PRP is like a Kia. So they are very, very effective cells. So stem cells help to create new cells in existing healthy tissues and also help repair tissues in those structures that are injured or damaged. So if you have this is called mesenchymal stem cells they usually use, and these are something we call undifferentiated cells, means they have characteristics to change, to replicate in the joints you inject in. So they can convert into the bone cells when you inject in the bone. They can convert in the tendon or muscle cells when you inject in the muscles. They can convert in the fat when you inject in the fat. They can convert in the muscle tissue or cartilage or in the bone marrow. So wherever you inject, they differentiate or replicate and change to that particular cell needed. So compared to like white blood cell, if you inject white blood cell in the bone, it's not going to turn into the bone cell. So it's not going to help to grow the bone. These cells do. So they have two main characteristics. One is the self-renewal. They reproduce and they can replicate themselves indefinitely. On one cell, if they survive, it can keep replicating again. So it just basically doubles up, and it will do in the same tissue that you want, or the same tissues they are injected or placed in. Potency means they have differentiate into the specialized cell where it's needed or the way you want. So as we say, that if I inject in the bone, it's gonna be bone muscle, not the tendon muscle. It will replicate as a bone muscle. So stem cell therapy. The stem cell therapy is designed to target areas within the damaged tissue to help with the creation of the new cells. If there is a damaged tissue, means those cells are dead in that tissue. We need to create the new cells. The mesenchymal stem cells that we use they are undifferentiated cells, and they are multipotent, means they can replicate themselves, they can same thing, like they can become the same cells you want, bone cells or the muscle cells. They are also, again, natural anti-inflammatory. So if the tissue is damaged, there is a chronic inflammation going on, swelling going on, they also help to get the, get the inflammation down, and that automatically reduces your pain and swelling. So there are 3 types of stem cells usually the embryonic stem cells, induced pluripotent stem cells, and adult stem cells, also known as the mesenchymal stem cells. Embryonic stem cell comes from the embryo. Induced pluripotent stem cells is basically you get the stem cells and you put on the dish and you grow them and in the culture medium. And then adult stem cell, mesenchymal stem cell, that's where you get from different tissues in your body, and basically you get, usually we get from the bone marrow aspirate or the adipose tissue or fat. Embryonic stem cells and induced pluripotent stem cells are illegal in United States because it's more something we call more than minimal manipulation, so it's against the regulations. Embryonic stem cells and sometimes the induced pluripotent stem cells is also known as teratogenic, means if you inject them, they can lead to cancer formation because they're really not undifferentiated and multipotent. So they can cause damage more than help. So what we use in the United States, mainly we use something called adult stem cells. And we use an autologous source, means your own. There is an allogenic source too, that's FDA allows us, and that's something called amniotic fluid cells and placental cells. But we mainly like to use your own. So we don't have to worry about the cells coming from someone else or if those cells are viable, alive, not alive. There are lots of controversy there. So we like use your own cells. So there is no risk of rejections or anything. It's your own. And usually these cells found in all tissues and organs of the body. They always function to repair or restore damaged tissue. They retain the ability to divide while maintaining an undifferentiated state. So they keep dividing and replicating themselves, but they still say undifferentiated. So whenever they need, they go there and make a tissue. They also exhibit plasticity, which means they are easily influenced by their environment. Now in the medical field, they also call this as a medicinal signal cells, MSC. Instead of mesenchymal stem cells, they say medicinal, because now we're using as a medicine to cure the diseases and everything. Normally, if you look under the microscope, many of these cells are just attached to the blood vessels, right outside of the blood vessels. And as soon as the body signals them that they need it somewhere, they migrate in the blood to the tissues you need. The problem is that if the tissue is injured, there is no enough blood supply, not enough stem cells can migrate there. So then we have to get from somewhere and inject and bypass the blood vessel to get the stem cells in the damaged tissue. That's why the injection came important to do the injections. And when you do that, they start differentiating, healing the tissue. Again, they will regrow the blood vessels, and the blood flow starts to that body part, and it starts healing. No problem. How we do that bone stem cell things? As I said, the two main stuff to do is, one is to get from the bone marrow, like a bone marrow biopsy. The other thing is called adipose tissue from the fat. From the bone marrow biopsy, the most commonest place is your iliac bone, from the back of the iliac bone. That's where we get from it. There are people who get from sometimes in the vertebral body, means your backbone, in the spine bone, but they do that when they are trying to use those stem cells to help some kind of the spine surgeries. And mainly that's done in the Europe and not the United States yet. So we put under the anesthesia, under the fluoroscopy guidance, basically we numb up the targeted areas very well. The only part of the bone hurts the most is just the outer part called periosteum, and that's the only painful part. So we put the needle there and we inject the numbing medicine to numb up very well there, and then you feel only pressure. You don't feel really the pain there. And then we put the needle. You can see this is the bone here. and this is where the iliac bone, from the back of that, we put the needle through that in the bone cavity, and there's a bone marrow fluid there. And we aspirate that bone marrow fluid. So you can see that you can aspirate bone marrow fluid, then centrifuge, the same way we do the platelet-rich plasma. You have to spin it a couple of times, and then you get concentrated bone marrow aspirate. So it's known as bone marrow aspirate concentrate, BMAC. So you can see these bone marrow stem cells. The one stem cells can be differentiated in many, many different cells. So it depends upon where you inject, where they're needed. They will differentiate in that particular cell to heal that particular specific tissue. The adipose harvest means bone cells or the bone marrow cell or stem cells from the fat. So sometimes we use the special cannulas to basically absorb or suck the fat from particular areas. Commonest area is usually in the flank areas here. So you need about like 400 cc's of adipose tissue to get 6 cc of bone marrow concentrate. So use the special cannulas and aspirate the fat. Then you kind of washing the fat. You have to transfer from one syringe to other with the filter thing to filter some of the unnecessary stuff. Then there's a different way to do. Some machines have gravity sedimentation. You leave them upside down, and all this lipid and the oils comes up. The main fat stays down there. Some techniques uses the centrifugation, like you just centrifuge them. Some there's physical separation with a mechanical. Someone has a mechanical vibration thing, and they can separate the fatty tissue and the lipids and oils, because you don't want to inject lipids or oils, because those could be toxic, and it can lead to more inflammation and damage than help. So you have to get that out. So studies have shown that the adipose tissue contains as much as 500 times more stem cells than those seen in the equal weight of bone marrow. So adipose tissue, the fat has lots of stem cells. And the same thing with the adipose tissue, cells will differentiate in a different tissue cells, same as the bone marrow. So advantage of stem cells, you get lots of stem cells out of the adipose tissue. And it's usually in the older population, you have more stem cells in the adipose tissue than the bone marrow. Obviously, bone marrow stem cells has less volume as you get older. Disadvantages of getting the stem cells out of the adipose tissue or fat is they are locked in the collagen matrix in the fat. So to get the stem cells out, you have to break up the fat. And it's very hard process, not easy. And when you break up the fat and you get this nice clear liquid, that's called SVF, or stromal vascular fraction. Otherwise, you doing is kind of fat grafting. Means when you get those lipids and liquids and all those things out, we have like little thin but thick layer of this fat tissue that you have to inject. So it's close to something called fat grafting. You cannot do that everywhere. You cannot do in the big joints, but you cannot do in a small joint, because you're not going to be able to inject. You cannot do in the lumbar disc. You cannot do in lumbar facets because it's too thick for those. You have to have liquid. So stromal vascular fraction can only be obtained, or you have to digest the fat. Whatever you aspirated the fat, you have to digest all those fat out to get that stem cells in the fluid, in a fluid manner, because you don't want to inject the gooey thing. It's not going to work in a particular area like the disc, facets, as I say, or the small joints. So the only way you can get it, you have to use just special enzymes called collagenase and some other stuffs, or very high frequency vibration thing to separate the stromal vascular fraction or the thin fluid out of the fat. In the United States, it's not easy to do it. FDA recognized that as a more than minimal manipulation of the mesenchymal stem cells. It's kind of against the regulations. The reason you don't want to do mini-put manipulation of mesenchymal stem cells at this point is because it's considered violation of the human rights and you name it. Plus, it can lead to more problems because it can become a teratogenic or it can lead to the cancer formations if there is a change of the mutate during this more than minimal manipulations. So adipose derived stem cell therapy is kind of gray area. Some practices around the United States do that, try to bypass that using different kind of machines, but they are not really getting the same exact SVF we need. There's always some gooey material. And if they use a collagenase, they use the different ways, like they go under some review board or something just to bypass the FDA thing. So if someone doing this in a private practice, there's a possibility FDA can come and shut them down anytime, and they can actually prosecute them. So combination of PRP and stem cells. But before that, we're gonna say, what's the difference? What's the difference between PRP and stem cells? As I said, the difference like Kia and Lamborghini. So in terms of clinical effects, they did this one study on the wound healing using either nothing, only PRP, or PRP and stem cell combination. So they got some healthy volunteers and they made 3 laser burns in the same arm, few centimeters apart. And then one area they applied nothing. The second area they applied platelet-rich plasma only. And the third area they applied platelet-rich plasma and adipose-derived stem cells or stem cells. After day 6, you can see the wound is still there. It's not healing as much as we want. PRP is healing much better than this one. Look at this. It's almost healed by day 6. Day 14, you still have the healing process with that shiny keratinizations. This one, PRP plus stem cells, is almost gone, almost healed. The PRP is healing better than this. So when we do the PRP and stem cells, what do we do before and after? The steroids, any kind of prednisone, steroid injection, steroid by mouth, and NSAIDs, that's anti-inflammatory, ibuprofen, indomethacin, naproxen, high dose of aspirin, all those things inhibit wound healing. They inhibit with the platelet functions. They will really suppress the inflammation needed to start healing process. So usually there is a recommendation not to use steroids and NSAIDs or anti-inflammatory about 1 to 2 weeks before the procedure and 1 to 2 weeks after the procedure, and give the PRP or stem cells chance to work better. Local anesthetic and contrast could be toxic to the stem cells. They say for platelet-rich plasma, local anesthetic and contrast is okay, doesn't affect. When you doing the stem cell injections, we really cannot make stem cell fluid with the local anesthetic or the contrast because it can destroy the stem cells. Antibiotics can be cytotoxic. Some literature says it's not cytotoxic or the toxic to the stem cells. Some literature says no. So we don't know yet. So if we don't know, we don't use. Contraindications, very common thing. If someone has a cancer, active chemotherapy, radiation therapy, obviously we're not gonna do it because it's gonna destroy the cells. Chemotherapy will destroy the stem cells and won't be effective. Anticoagulants is contraindication if you cannot stop. So if you're doing the injection in the lumbar disc or lumbar facets, and if you want anticoagulants like Coumadin, Plavix, Affion, Brilinta, Xarelto, we need to stop that. And that's not, anticoagulants not gonna hurt stem cells or PRP. It just, you wanna make sure you don't bleed. So it depends upon where you do the injection, where you going to do the injection, either you stop or you don't stop. So that one usually falls in the same category as other injections. Obviously, infection, local or systemic, you don't want to do any injections. If someone has severe osteoporosis, you have to be careful with the bone marrow aspiration. It's not absolute contraindication, but it's related contraindication, making sure you don't break the bone wall while putting the needle in. Too severe pathology in area they're targeted. If someone already have a really bad knee osteoarthritis, it's the knee is locked, it's bone to bone. Now there's a different definition of the bone to bone, but the bone to bone means sometimes they have so bad arthritis that they destroy whole joint. Now they might not have any pain there because there is no endings left. All no endings died because it's so bad, and they are more of locked joint. Then it's not gonna work. You have to have some tissue, as they say. You have to have some tissue there to regenerate. And if your loan is completely dead, you cannot regrow. If there's some loan left, you can fertilize, try to grow it back. So again, pre-injection protocol. Anti-inflammatory have negative effect on the platelet function and may decrease the growth factor release. That's why we don't want to use anti-inflammatory 2 weeks prior to the procedure, 1 to 2 weeks they say. So most authors recommend stopping 5 days before and up to 2 weeks post-injection. I usually do 1 to 2 weeks, depends upon they can stop or not. I have patients I have not stopped because they cannot stop. They say if they stop the anti-inflammatory, all joints in their body will flare up and hurt. Then I will take a chance, because I don't want to make them to the so painful that they're not going to even realize if it's working or not. What to expect after these treatments? It's normal to feel very sore for up to 2 weeks after the stem cell therapy or PRP. These injections leads to release of growth factors, and what it does is the growth factor starts with the pro-inflammatory response. Means once you inject these, platelets gets lysis or stem cell gets increases the inflammation initially for first 1 to 2 weeks. So when the inflammation is going up, obviously your pain is gonna go up. Your pain may get more sore. Starting the inflammation is the key to heal the tissues. If you notice, if you cut your skin, the first thing you see is getting red. That's inflammation, and then it slowly heals and goes away. So inflammation is much necessary. For the first 48 hours, you should rest the area and use as tolerated. So if you don't have increased pain, your pain is better somehow, don't go and start torturing that area, torturing that joint. You have to wait. For the first 2 weeks, you should start some light stretching and range of motion exercises, very slow. 2 weeks after, you can start progressively increasing your exercise, strengthening exercise, or physical therapy. Many physicians refer patient back to physical therapy. Most of the patients we see is they already have lots of physical therapy done, and they know how to do home exercise programs. So I usually tell them, hey, if you haven't done physical therapy, I want you to go back. If not, if you have done, you know what you're doing, then you should do at home as a lifelong homework. The maximum results for this treatment usually you won't see until 8 to 12 weeks. So you may have increased pain for first 2 weeks, then you won't feel any change. So your increased pain will go to the baseline, and then you won't feel anything. You feel that, oh, this is not working. This is not working. This is not working. By the 8 to 12 weeks, you're going to realize that it's definitely worked. So you may not see the difference. So that's the big difference between steroid injection and then PRP or stem cells. Steroid injection will make you better 1 to 3 days, maximum 7 to 10 days. This one won't do that. Remember, this is the natural healing process. It takes 8 to 12 weeks. Do you need the repeat treatments? Yeah, possibly you may require 2 to 3 treatments to get the maximum relief. That's not true in all cases. So what do? We do 1 injection, we wait. I wait up to 12 weeks before I even make any decision doing any further treatment. If the first treatment helped you some, not enough, at 12 weeks, then I will recommend like, hey, have a second treatment. This is more common with the platelet-rich plasma. The stem cell treatment usually works much longer. You may not need the repeat treatment because they are much more powerful to take care of the tissues. So stem cell therapy most of the time is usually combined with the platelet-rich plasma injections. So means we draw your blood, and when we prep your platelet-rich plasma, when we do the stem cell injections. And the reason we do that is because PRP creates a sticky fibrous network in the tissue injected. PRP is a little bit sticky, so when you inject it, it's like a glue. Then when you inject the stem cell fluid, it basically that fluid gets stuck to that glue, and the stem cell stays in that area for a long time. So other concern is to making sure if you inject the stem cell fluid, it's not leaking out. Because if it leaks out, it may not work. So sometimes we inject PRP. It also depends upon where you inject. So you can do that in a big joints, in the disc, like if you're injecting in the low back, lumbar disc, it's hard because the disc can hold only certain amount of the fluid anyway. So if you combine with the PRP, you may not be able to inject as much as stem cell fluid you want. But it all depends upon how the disc looks. If you think the disc is leaking, then it's better to inject PRP and stem cell together. If disc is not really leaking, it's just a degenerative disc, you can just inject the stem cells. So there's something called stem cell farming. That's what the PRP and stem cell combination does. So stem cells are the kind of the seeds. The PRP and the growth factors, cytokines are like fertilizers. So they help for the stem cells to replicate more and stay more in that area, so they can keep differentiating and getting more and more cells there. The surrounding tissue is the soil. So basically you're fertilizing the surrounding tissue soil with the PRP, and then you're putting the seeds in the tissue to grow your lawn or the plant or the trees, what do you call. The vascular supply is the rain or moisture. So the platelet-rich plasma and stem cell combination will, as I increase the blood supply to that tissue. So that will bring more and more nutrients to the tissue to help. So it's not just your PRP, not just your stem cells that we injected, but those combination will also stimulate and bring more stem cells from the other side of the body, from other parts of the body. They attract, so you're getting lots of stem cells there. Plus you need oxygen. So if the blood vessels regrows and the blood starts coming, you get the oxygen there. That's vital for the tissue to form. What we treat with the PRP and stem cells. This is the sum of the common indications: osteoarthritis of the joints, tendinopathies, acute sports injuries, sacroiliac joint pain, degenerative disc disease, disc bulging, herniated disc, facet joints, carpal tunnel syndrome, piriformis syndrome, and this is the sum of the things. Okay, so gonna go quickly through the pictures what I'm talking about. So shoulder joint, you can inject inside the shoulder joint to help with the arthritis of the shoulder. And this is ultrasound guidance. You can use the X-ray machine, the fluoroscope. This is how the shoulder joint looks in the ultrasound guidance. So we just do the injection. We can see the needle tip going in the joint. So we know, and we are 100% sure that we are in the joint, not outside. Rotator cuff tendons. The people you say, oh, I have shoulder pain, I cannot lift the arm up, that's rotator cuff. And under the ultrasound MRI, you can see sometimes the partial tears in the rotator cuff muscle. Your MRI report will say partial tear, or MRI report will say tendinosis or tendinopathy. That means it's a chronic inflammation. So you have this inflammation going on for a long time. So that tendon has lots of scar tissues inside, lots of chronic granular tissues from the scarring, and it's chronically inflamed. So it's not dead, but it's not functioning well. So anytime you stretch that scar tissue inside the tendon, you're gonna hurt it. And they get really big because it's all unnecessary stuff there. So you're getting more and more impingement. Tennis elbow, that's outside of the elbow. Same thing, you can, if you look at the MRI, sometimes you have partial tear, inflammation. Golfer's elbow, that's inside of the elbow. Tennis elbow doesn't mean only tennis player gets it. Anybody who can working a lot with the hands and wrists can get that. Hip tendons. Lots of people have hip bursitis. We call hip bursitis, it's a layman term, but I would say 99% of the patient does not have hip bursitis. They have tendinopathy, or tendinosis means chronic inflammation. Bursitis, itis means acute inflammation, and tendinosis means the chronic inflammation. And most of the time we see the patients, we say, oh yeah, if you have hip bursitis, because that's how we understand, but they actually have tendinosis. And some of your patients, some of you guys are suffering from them. You come, we do the cortisone injection, your pain gets better for a week, 2 weeks, 2 months, and starts coming back afterwards because steroid effect is gone. That means we're just masking that inflammation temporarily. We're not treating, we're not healing. Actually, if you do the steroid injection more often, you can make more damage and you can increase the tendinosis more instead of helping. So we can do the hip joint injection with the same PRP or stem cells inside the joint for the arthritis. And there is actually the paper out there, study out there, they did the MRI before the injection, after the injection, and MRI 3 months after the injection show almost 90% decrease in osteoarthritis changes. So it reverses, not just getting the pain down for months and months, but it reverses the osteoarthritic changes. We do for the Achilles tendon. Someone has a Achilles tendon tear or Achilles tendinosis. Lots of athletes sometimes have the Achilles tendon tear. They tore the tendon, tear the tendon. They go to the physiatrist or the pain management doctor, orthopedic surgeon. Sometimes they inject the platelet-rich plasma right away, and they go back to their spots within 3 months. If you don't do anything, they're probably out for 6 to 9 months minimum. Knee joint, very commonly injected joint, very common for the osteoarthritis, very, very common for the pain. It works charmingly. Plantar fascia, the patient has plantar fasciitis, lots of foot pain because of the arch problem or the fascia problem. It works very well. It regenerates and reverses the changes that's happening. Chronic plantar fasciitis, you have the same thing. You have the chronic inflammatory changes in the tendon here where it attaches to the bone here, so it keeps hurting you a lot. Back pain. So we can inject in the disc, we can inject in the facet joints right here. Obviously there is not everyone is candidate for that, but for the degenerative disc, patients who have pain coming from the disc, small disc herniations, all those are kind of indications you can have PRP stem cells to help. It does not help for something called spinal stenosis. Spinal stenosis is basically significant growth of the ligament here. If the facet joint arthritis can cause this joint gets bigger, then you have some disc bulging coming out. So combination causing narrowing of the hole here, the central hole, or the hole on the side here, pressing the nerve, got spinal stenosis. Obviously that does not get better with PRP stem cells at this point, because we cannot put any PRP stem cell there. We don't know how it will react yet. But definitely if you have degenerative disc disease or pain coming from the disc pain, something called discogenic pain, then it definitely helps. The facet joint pain coming from arthritis definitely helps. The other thing PRP is used is something called vampire facelift or vampire facial. And sometime next month I'll be also lecturing on aesthetic PRP stuff. It's very interesting. Hair restorations significantly used. Lots of studies getting published that injecting PRP can regrow the hairs where you're losing the hairs. Lots of centers using for the wound healing. People who has problem with the wound healing, like the decubitus ulcers, patients who went with the bed for a long time and they develop the ulcer that won't heal for a long time, will never heal. They started putting PRP and stem cells instead of actually the skin flap, and they are progressively getting better, very faster than normal treatments they do right now. So what we can do, definitely not these. These need surgery. When you fracture the ligaments, obviously you can inject in the ligaments and you can make it better. Once you have sprain of the ankle, that ligament is weaker forever. You're never gonna make it ligament stronger just with the normal treatment. You're always gonna have weakness. You're always prone to sprain that again and again because it's weak. It's not stable. So you can do PRPs, stem cell there to make them stronger again. So who uses PRP stem cell therapy? This is just the shortest list. He did it. He did it. He did it. Obviously, he did it. He did last year. He has Achilles tendon tear, and he was back on the floor, I believe, in 6 weeks. He did in his neck, cervical disc. He did out of United States, but he did in the cervical neck area, and she did it. This is vampire facial. And that's all for me. Yes. No. We're injecting your own, so there is no blood compatibility problem. It's your own blood. Yes.
Dr. Patel, I understand the concentration effect of numbers here. You're increasing the numbers of the right platelets at the right place. I understand the concept. Could you talk about chemistry? Why is it not absorbed at the same rate that the normal amount of restorative attention to that area? What are you using other than your numbers of platelets, of good platelets?
So why the body is not healing itself?
Well, why is the body not just taking away what you're putting in at the same rate as it always has?
Because when you have injury and have the scar formation or granulation formation, you lose the blood supply. So you're not getting enough blood supply in that area. So if there is no blood going, there is no platelets going, no growth factors is going there.
So you are injecting into the interstitial area or directly into?
Directly over those tissues. So if I have a tendon problem, you inject directly into the tendon.
That's the targeting that you're doing?
Correct. If you're injecting the joints, obviously you inject right inside the joint. And as I say, when you inject the PRP and stem cell, it sticks there. And then it stimulates. It just signals the stimulation. So only injecting 2 million platelets is not making difference. It's just, along with them, releasing the growth factors, they're stimulating the body. They're calling the body like, hey, I need help here.
Could you respect the list that you had up there and reflect on which of the items that you had up there that you're using it as treatment, which ones has been most effective for you?
For me, I have, it does vary from the patient to patient or the conditions. So far, I have used the most successful. I have the sacroiliac joints, lumbar disc, lumbar facets. I have 1 cervical facets injections. The other one I think was a lateral epicondyle or tennis elbow. This patient came with the actually near full thickness tear, so almost torn. She can so much pain she cannot lift any cup because it's a pain and weakness. I did only 1 PRP. I saw her back in 2 weeks. She said after 5 days, her all pain was gone, or all her stent was back. The other thing I did is knee joints, hip joints, shoulder joints, elbow joints, all successful.
You still have to go in there and clean it out, right?
But the way we do with the rotator cuff or the tendons who has a chronic inflammation is we do something called tenotomy. Tenotomy means we put like bigger gauge needle there, and basically we fenestrate. So we break it up. So we break it up, those scar tissue on those tendons first. by doing some passing. It's not a huge pain or anything. You just pass 10, 15 times. You put the needle right there. You break it up, and then you put the PRP. So I don't know if you guys know, with the lawn is dying one side, and there's a green lawn. You cut it lawn, it will grow. The same concept. Yeah. Yes. But if you use if you use the cortisone during the RFA procedures, you have to wait for 2 weeks before we go for this procedure. But if you have RFA done before and it helped you or didn't help you or help you, a short period of the time, yeah, you can have this procedure.
So if you're a cardiac patient, which drug is the one that you're probably going to say stop before you do this?
Anticoagulants? It depends where I'm doing the procedure. So if someone taking aspirin 81 milligram for cardiac or the stroke prevention, I usually don't make them to stop that. It's a very small amount. It does help to prevent the stroke or the heart attack, but it really doesn't affect the platelet functions. If you're doing the lumbar disc procedure, I will definitely ask them to stop the blood thinner. So if I'm doing the joints, usually I don't stop. If I'm doing the sacroiliac joint, I don't stop. If I do the knee joint, shoulder joints, I don't stop. Now, if someone taking the Coumadin, and day of the procedure, we check the Coumadin, the Coumadin is 4.0 level, I won't do it, yeah. So we check INR and making sure, if it's less than 3 or something, it's okay.
You did work on me about 7 years ago, and I got relief for about 3.5 to 4 years. Who told me this going to last? Am I a candidate? I was a bulging disc patient. I got good results.
Yes.
The procedure that you used at that time, am I a candidate for this? Oh, by the
If
way,
it's
3 years after triple bypass. So, am I a candidate?
Yeah, you are candidate. So if I have to do, let's say if someone has a disc issue and they want me to do the procedure in the disc, I have to make sure that everything else has been ruled out. So the most common other stuff is facet joints. So usually I do the diagnostic block, making sure it's not the facet joints, making sure it's the disc. Now if we come to the disc, I strongly recommend to have something called discogram done, just to prove that it's definitely the disc pain.
It just so happens I was a facet patient. So.
Right. So if the facet pain, if someone comes with the facet pain, obviously we want to make sure it's facet pain. Now if I have seen this patient for the facet pain, I did the procedures, they always got the good response. Other diagnostic blocks were 70, 80, 90% better. The RFA worked, but didn't work 6 months, worked 3, 4 months. It's still considered as facet pain. Then I'll go straight to do I can go and do the PRP or stem cell. If someone comes and say, hey, I need something in the disc, first we have to prove or determine that it is a disc, because this is expensive treatment. You just don't want to go like, yeah, it's disc, let's inject $7,000. It doesn't work. Yeah.
We talked about three different types of stem cells. One that you extract from the bone marrow.
Right.
One that you extract from the fat. ADSC.
Yes.
And then stem cells extracted from your blood.
No, that's the PRP.
That's the PRP.
Correct.
Okay.
The other kind of stem cells it's in the market is it's called amniotic fluid and placental. So amniotic fluid cells, they usually is a pre-made, and that has been that fluid has been extracted from the mother's amniotic fluid after the delivery. Yeah, after this, and mainly that's from the cesarean section. And in that case, they actually have a consent from the mother when they got pregnant. They monitor the mother whole time, and they don't pay the mother for that.
So if I were to come in and I say I've got lower back pain and I've got fasciitis, so can you treat both at the same time?
Yeah.
You extract the stem cells, send it down, and you just
Mm-hmm. Can I treat the multiple parts same time? Yes.
Can you give me a round figure of what maybe an average figure how much it costs to have this done?
John. The yeah, PRPs I would say around, if you're doing one body part, is around $950. Stem cells starts around 4K, 4,000.
All right, then if we do multiple, if it lasts expensive, then do it at 2 different times.
Where we have buy one get one second 50%. BOGO. We have BOGO.
And then when I come into my first appointment, how long will it usually take to go through all the processes that you need to do in order to do the surgery?
So if you fail this one, or are you talking about the procedure?
If I come in for my first appointment, and then you have to do MRIs or whatever tests, test whatever you need to test, and do the procedure, how long does that usually take?
So if you come first visit same year, let's see if you don't have X-ray MRIs, I order those, see you back with those tests, go over the results, and depends upon what we find and how we gonna decide. So if it's facet pain, obviously you have to go through the diagnostic blocks first. If the diagnostic block is successful and you say, listen, I just want to go for the stem cell, I don't want to go for RFA or something, obviously a week after diagnostic block we can go and do the stem cell injections. So I would say 1 to about 3 weeks, 4 weeks. I mean, we have X-ray MRI machines here, so we actually accelerate the process about getting X-ray MRI done. Yes.
I think you answered that question, but about the baby cells, if they take it from
Yeah.
the newborn baby, they can do that? I mean, say I came to you. and
It's
I-
not baby cells. It's from the amniotic fluid that's outside of the baby. It's a water.
Okay.
So
And
that's
they have-
that's FDA approved.
Okay, and that is approved.
Yes. So they take that, they process that, they treat, and they did all this treatment. They actually go through the ultra radiation, all those things. Obviously, they follow the mother whole course, just making sure there is no diseases, anything. Oh yeah, they follow.
Okay, and that is approved.
They process, extract radiation, and then they freeze it to minus 42 degrees centigrade or Celsius, and it comes in like 1 milliliter vial to us, same temperature.
Does that work better than taking your own? Than taking your own?
We don't know yet. Honestly, when I spoke to the scientist who works with the stem cells in one of the conference, and they gave me honest answer, don't use it. Good. They said there are no stem cells in that fluid. Those stem cells are almost is dead. What they have there is probably concentrated growth factors. So if you want to use that, you may just go and use a PRP,
PRP,
platelet-rich plasma, your own. Yeah.
your own.
And that has to be done in a certain period of time. Like, I mean, when they take it,
Platelet-rich plasma?
yeah.
Yeah, it's usually good about 4 hours at a room temperature.
And age, now, the way I understand it, age, they say that platelets are not as strong. Say I'm 80, in the 80s.
Well, it depends upon how many platelet counts you have. So if something affecting your platelet count, I mean, your doctor does the CBC, right?
Right.
So it shows the platelet count. So if the platelet counts come back less than 60,000, then you really not candidate, because then you cannot concentrate.
Okay, so you would have that checked first then,
Yes.
before you did something like that.
That's a normal.
Normal.
That's a
thing
normal
to do.
thing. Well, I'm asking.
But it's normal. It's not normal, but we have suspicious. Now, most of people know if they have less platelets or there's problem with the blood cells. They know it before they come to me. If they say, oh, I'm not sure, I never had been checked, then I may order making sure. Yeah.
There was talk back when I was in school that there's a limited number, a finite number of T cells in your body. Is that true?
That's true, but there are like different kind of T cells.
But you're saying that they do reproduce as numbers diminish?
You mean T cell or stem cells? T cells are different than stem cells.
Okay. I guess I was addressing T cells and I'm confusing stem cells.
No, T cells are different. T cells are one kind of the white blood cells. The stem cells are just mesenchymal stem cells. The T cells and white blood cells come from the bone marrow. So the bone marrow has two kind of stem cells actually. The one is called hemopoietic, and those are the one makes platelets, white blood cells, red blood cells, T cells, all those things. And then you have.
They're being refurbished all the time.
They have been refurbished, but they cannot they are not undifferentiated. So if you inject those ones, they're just gonna reproduce in the T cells or the white blood cells if they can. In the tissue, actually, they cannot reproduce even. Only area the white blood cells, red blood cells, and platelets can reproduce or produce is the bone marrow, nowhere else. While the mesenchymal stem cells, they can replicate in other tissues undifferentiated, and they can differentiate as needed. So when you get that bone marrow aspiration, that's why you have to spin it to get the concentrated mesenchymal stem cells and get rid of the hemopoietic stem cells. The same way you get rid of the red blood cells from the platelet-rich plasma. The needle I use, there are two kinds of needle. The one is just the large bore needle where you actually aspirate 60 to 120 cc of bone marrow aspirate or the bone marrow fluid, and then you spin it to get the concentrated. I use a special needle that has very small holes, around the needle, and when I aspirate, because of this very strong vacuum phenomena, I'm getting only mesenchymal stem cells in that fluid, so I don't have to spin. I can just aspirate and inject same time. Yeah. Yes. But you probably not donating just platelet, you donating plasma.
Well, most of the time they've been taking just platelets, but every once in a while they're actually
How much they correct. So they're doing the same thing, but they are getting your getting the whole blood out, and they're spinning to get the platelet to get rid of the red blood cells, and you donating platelets. You cannot separate platelets right here. You have to spin it.
Suppose you have an ankle that has no tendons in it from an accident. Can they put stem cells or something like that into that to ease the pain?
It can ease the pain if it's absence of a tendon leading to like arthritic changes and everything. But obviously, if you don't have tendon, you cannot regenerate the whole tendon through the stem cells. No. You have to have something. So if you have tendon or ligament presence there and it's probably torn or weak, you can inject that, then it can make it stronger and grow it. But if there is nothing there, you cannot. Right. So we cannot grow the third arm by stem cell. No. But I say military is working on it. They are successful growing nose and ear. I mean, I don't know how long. Right, but I don't know after a few years if that nose or ear is getting cancer formation or not. Yeah.
I really apologize for going back there with platelets or the
Q test? Key, yeah.
Talking hundreds versus thousands. I'm sorry. The next thing is can we make a phone for private, not just business? I've got a lot of questions. I'm sure we're going forward.
Yeah, certainly. Yeah, you can make appointment. Yeah.
Of the three mechanisms of pain
I use bone marrow because, as I said, the adipose tissue is a gray area. With the bone marrow, I can get that liquid form that I can inject anywhere. Where other adipose tissue, they have system out there, but you kind of doing like fat grafting. It's a very thin but thick gelatin material. You cannot inject in the disc. If you want to inject in the joints, you have to use a large bore needle. Could be more painful because you may have still some lipids, oils left, and they can irritate the tissues.
On spinal stenosis, you said this is not a good treatment for that. So what is the treatment for that?
It's mainly the surgery. Because spinal stenosis, it's just like roadblock happening because different tissues getting larger. You have thickening of the ligament. You have the fascia joints getting arthritis, so you're developing those bone spurs. And usually they grow where there is a space there, and the space is in the canal. And obviously your disc layer is weaker, so your disc is bulging out if it's not herniated. So the combination makes the narrowing of the spinal stenosis. It's more like bony structures. So only way you can really help that is you clean it up.
Is that done arthroscopically?
But here we do both ways. There are laser, and there are three things: are the laser discectomy, other is like laminectomy discectomy, and the third thing is fusion.
Do you do the laser after the stem cells?
No.
You do that separate.
Right. There's a practice I heard. They do the PRP stem cell injection and do the laser in same area. So they're treating and killing.
And the PRP injection, that is the blood taken from your own cells.
Yes.
Okay. And that would relieve the pain, say in the shoulder or something like that.
Yeah. Platelet-rich plasma. You can inject anywhere. PRP and stem cells, they are the same treatments. You can use at the multiple.
And you would decide which one should be done?
Yeah. Yeah. In my practice, most of the time I tell them to try platelet-rich plasma first.
Okay.
Unless you have enough money to make me rich, I take it.
Not today. But you would do testing to make sure what's going on in the different parts of the body first.
Correct. Yeah.
My wife's getting steroid injections now, so we go with this particular type of injection. Is that going to do the same thing as steroid injection plus, or like she gets a steroid injection and all that?
This is gonna really gonna heal you. If she needs, let's say 1, 2, or 3 treatment max, she won't need steroid anymore. With the steroid, you temporarily reducing the inflammation, but you're not healing anything.
So like the slide said, it take a little more time, but it does arrive and be a
Yes. So if I do someone of the platelet-rich plasma injections, I won't do anything for 12 weeks. Unless they are in a severe pain or they have effusion and I have to go in the knee and figure, but it never happens. But I'm telling you, first couple of weeks you have increased pain, and we usually try to tell patients again and again, like, this is gonna happen, so don't get upset. After that, you feel, yeah.
I was wondering, when you said the PRP, is there a reason why you didn't also do stem cells?
For you?
Yes.
Because as I said, I usually start with the PRP first. I always try to do the PRP first and see how it works.
Okay.
Correct, because the price range is so varied. So I do have a patient who has a lumbar disc issues and came from, I think, 3-4 hours away. Never saw him before. He just came and said, listen, I have these 3 disc issues known. I know it's a problem. Only thing I want you to do is inject stem cells. Nothing. He doesn't want epidural. He didn't want to try PRP. He said, only thing I want is stem cells. So I did that stem cell injection because he wanted that. I mean, he was a middle-aged person. he had increased pain for 3-4 days. After 5th day, his back pain was gone 100%. We saw him couple. Yeah. Yeah. And if I do PRP stem cells, I charge for stem cells, not PRP. It's included. No. Class 1, no, I don't. There is anecdotal reports. There are no scientific reports that has it works. So it's like it works in some patients, doesn't work in other patients. Insurance companies really don't pay for that. So do the patient ask me about that? Yes. I tell them, like, if they want to try, that's fine. It may give you symptomatic relief for weeks, 4 weeks, 6 weeks. Same thing like, you know, the spinal decompression thing. It works definitely for some patients, but it works temporarily. But it's a really out-of-pocket cost. This is out-of-pocket cost, but there are more promise here, no side effects.
Have you looked at any studies that incorporated that along with
Laser? I haven't looked at it, but only the reports, the scientific reports we see on conference and the articles, usually the PRP and stem cells. I'm not sure if you want to do the laser on the same area we did the PRP and stem cells. Specifically stem cells, because when we do the PRP, most of the time we ask patients to use the heat more instead of the ice, because we want to make sure the platelet keeps functioning, get some inflammatory process going. For the stem cells, we usually want them to use the ice because it makes no difference. So I'm not sure if the laser treatment actually helping or damaging those stem cells because of the high heat. It also depends where you're doing the laser, where you're injecting. I mean, if you're injecting the lumbar disc, that laser, they say that laser 4 or the class 4 can reach to the lumbar disc, but I don't think so. Yeah.
Can you recommend any readings that we can do on our subcutaneous way for us?
The only recommendation is the Google. Lots of things there, but just be careful what you read. Unfortunately, even for the physicians, we really don't have the textbook. It's so new and so new stuff coming out. One day it's this, and second day everything changes.
What about the platelets? Is anything on that covered under insurance or nothing?
PRP, platelets? No.
Yeah, nothing under that.
Oh, I don't know. Come on, run. Tell him.
Would the insurance cover the diagnostic things?
Yes,
like
yes.
discogram and stuff like that? Even though
Yeah. So I have patient comes with the knee pain, right? They have knee arthritis. They want to try cortisone. I'll try cortisone. It works, but doesn't last longer. Then there's just something called visco supplementation, right? Like Synvisc, Orthovisc for the knee. That's approved by the insurance company and works for the osteoarthritis. So I will tell patient, like, listen, try that first. You know, it's covered. It's supposed to work. Try that first. If that really doesn't work, I do that. Oh yeah, I do that. But it's only for the knee joint. So if there is something that's working and it's covered by the insurance company, I ask patient to, or recommend patient to do that first. If that really doesn't work, then go for the other stuff. But with the new treatments with PRP and stem cells, I ask patient to try steroid probably once or twice. If not giving you long-term relief, no need to repeat it, because it's known that steroid can cause more damage than help when you start repeating the injections a lot.
she's at the vac center now, and they're still trying to figure out. They're still like injecting her here and injecting her there.
Right.
Multiple areas.
Thank you.
No problem.
My candidate. You haven't looked at my records lately, but you know, remember I mentioned her, right?
Yeah, yeah. Yeah, of course. Well, we have to start with the PRP, you know. And there's a stem cells better, yeah, but it's a big price difference, you know.
I understand.
And if the PRP works, but doesn't last long, then we have more confidence like stem cells really gonna help you.
I make an appointment to get PRP.
Okay, no problem. See you.
Okay. Call them up or will you?
Huh?
Call them or will you arrange?
Amanda. Probably can give her your name and she will call you to make appointment.
Okay.
Hey, her.
Amanda, will you call me, please?
I will. I think
What are you gonna call me? What?
Yeah, go ahead.
Never mind.
Did I hear you say
yeah,
that
if I get
you
your information, I'll give you a call tomorrow, or I can give you my card.
pain injections before you do the bone marrow, take out the bone marrow?
We're on the go.
Sure. So
Can you give you a,
Numbing medicine, you mean? Oh yeah. Oh yeah.
email me your
my sister had that done in the doctor's office,
Arnold,
just for diagnosis.
under William.
or not. I recognize that name.
She had done it. Does it hurt?
No. So the outer layer of the bone is the most painful. Once you pass that layer, usually there is no pain. So I numb up that area very well. I put lots of numbing medicine there and wait for 5-6 minutes, making sure it's fully numb. And then when you inject, when you enter the bone marrow space, it usually